Isidro Salusky, whose seminar title is there a clinical role for the performance of bone biopsy in renal osteodystrophy? Dr. Salusky is a distinguished professor of pediatrics at the David Geffen School of Medicine at UCLA. He's chief of pediatric nephrology and director of the Pediatric Dialysis program. In 1996, Dr. Salusky established a clinic for the assessment of bone and mineral metabolism in children with genetic and systemic disorders. He currently co-directs the UCLA Pediatric Bone Histomorphometry Core Lab, a full-service, state-of-the-art CLIA certified laboratory that processes and analyzes bone tissue. As a clinical translational research scientist, Dr. Salusky has focused his research efforts on the abnormalities of bone and mineral metabolism associated with chronic kidney disease in children. His group characterized the features of bone diseases across the stages of CKD and has provided the first evidence for the high prevalence of vascular calcifications in children and young adults treated with maintenance dialysis. I was like, we need to do a little muting. There we go. He also has studied the role of FGF23 in the pathogenesis of CKD, mineral and bone disorder, and co-chaired the working group that developed guidelines for the diagnosis and treatment of nutritional and mineral abnormalities in children with CKD. As a result of all these remarkable efforts, Dr. Salusky is an internationally recognized leader in the field of bone and mineral metabolism in children with CKD. So Isidro, we're so grateful to have you here with us today, and I'm really looking forward to hearing about your work, and then also thinking about how we at UCSF can take advantage of your bone histomorphometry core for our clinical and our research applications. So just a reminder to everyone to add questions to the chat as they come up, and hopefully we'll get to them all. And Isidro, thank you so much.
Okay, thank you very much, Kaletia, for your nice introduction. Good morning. Oh, I need to share my slides. Good morning, yes, everybody. Let me first do this sharing situation. And so I share. Can you see my slides?
Yes, looks good.
Okay. So yeah, thank you for your kind introduction. I'm happy to visit all of you today and to trying to tell you about the role of bone biopsies in renal osteodystrophy. And also, I'm excited because since January of this year, our lab is being finally, after so many years, CLIA certified. So we can start doing analysis for anybody for clinical diagnosis in addition to research. So, and we can talk about that later. So, the idea basically today is just to talk a little bit about the role of why I feel that real bone biopsies are important in the field of renal osteodystrophy, because a number of different reasons that I will try to explain in the next few minutes. So these are my disclosures. And so what I want to do is try to talk a little bit about the impact of bone biopsies on the diagnosis of renal osteodystrophy. For those of you who are not familiar with the procedure, make a comment about the biopsy in itself, the impact of some advances in bone biology on renal osteodystrophy, the applications of technique like immunohistochemistry, immunofluorescence to bone in CKD, and how from bone tissue we can go into bone cells in CKD, the value of biopsy as target therapy, and where the future of renal osteodystrophy is going. So many years ago, and this is kind of the spectrum of renal osteodystrophy, defined according to bone turnover. This is a paper that we published many years ago, but nothing has changed for adults or children. So it's a wide spectrum, and you go from patients who have low turnover to high turnover, and a group of patients with adynamic bone or osteomalacia, normal bone or mild lesions of secondary hyperpara, and osteitis fibrosa, which is the most severe lesion of secondary hyperparathyroidism. And some patients have what we call a mixed lesion, so a combination of some mineralization defect with secondary hyperparathyroidism. In the early 80s, we knew that aluminum was a main cause of this type of lesion of osteomalacia and adynamic bone. This issue almost has disappeared currently. And if you look about guidelines that we do for the management of these patients, despite these decades of this we basically follow calcium, phosphorus, and PTH, and to titrate therapy according to the different histological parameters that we think that these patients have. And nothing have changed. There are absolutely nothing. The only addition to vitamin D are the impact of calcimimetic. So this, for example, is the biopsy of a patient with secondary hyperpara. The green part is bone. This part area is the bone marrow. And what you see here is a lot of fibrosis and osteoblastic activity. So that typical lesion of secondary hyperparathyroidism. And before we perform the bone biopsy, these patients received tetracycline labeling in order to assess bone turnover. And you can see here the nice separation between the two times that the patient received the tetracycline labeling. On the other end of the spectrum, you have this lesion called adynamic bone. And basically, again, the green is bone, the white area or gray area is the bone marrow. And you can see here there are no cells. This is dead tissue, basically. There is no osteoblastic activity or osteoclastic activity. And when you look at the tetracycline labeling, you can see just a very faint uptake of tetracycline, which is consistent with the histology. So these are the two kind of the spectrums of lesions that we see in these patients, either adult or pediatric patients. Now, for those of you who are not familiar with the biopsy in itself, how do we do it? I use this type of needle called the Bordier needle. It was described by this French doctor in the mid-60s. And we have a trocar that allow us to guide the site of the biopsy, a sleeve that goes inside this trocar that is anchored to bone. And then inside this, then we remove the trocar and we insert this trephine that it goes inside this area and allow us to go into the trabecular, the two cortices of bone, and we get the sample of bone. And we remove the sample from this trephine with this blunt extractor. So basically, this is the iliac crest. This is the anterior iliac crest. Approximately 2 centimeters below the top of the crest, you do a small incision, and here is the needle inside the guide, and then that's when you obtain the sample of bone. It's a very simple procedure. It takes approximately 15 to 20 minutes. We do it under sedation. That's the anesthesia, that one of the anesthesia members of the team are responsible of the sedation of the child. When I started doing this procedure many years ago, my colleagues, the adult nephrologists, used to do also the sedation, and they say, Mrs. John, are you doing okay with a little bit of this or a little bit of that? But I didn't think that was the most appropriate for children, and so we always have somebody who was responsible for the sedation for this patient. And it's we have done almost 1,000 biopsies, a very benign procedure with minimal morbidity. So as I mentioned before, it's important to do tetracycline labeling prior to the biopsy. The patient takes 2 days of tetracycline, then 10 days off, and then 2 days later. And 4 or 5 days later, we do the bone biopsy just to assess bone turnover. When you look at the biopsy, the core that we obtain is this type, and then the bone is decalcified, and then with the typical, osteometric machine system, we can read the different structures. That criteria, is standardized by the ASBMR, and we make the definition of the type of histology on the specific patient. Now, when you look about the clinical indication, this is ASBMR 2018, clinical indication when there is excessive skeletal fragility in unusual circumstance, when a mineralized defect is suspect, to evaluate adherence to treatment in the malabsorption syndrome, to characterize lesion of renal osteodystrophy, that's plenty, to diagnose or assess response to treatment in vitamin D-resistant osteomalacia or similar disorders, and when a rare metabolic disease is suspected. So these are kind of the clinical indications for bone biopsies. Now, what happened in the field of renal osteodystrophy is that in the year 2006, KDIGO came up with a new definition of renal osteodystrophy, and it with the call now chronic kidney disease mineral bone disorder, CKD MDD. And the main reason is because now renal osteodystrophy is considered a systemic disorder of bone and mineral metabolism due to alteration of CKD, manifested by either one or the combination of the following: abnormality of calcium, phosphorus, PTH of vitamin D, abnormalities in bone and turnover, mineralization. I come back to this as renal osteodystrophy, and also vascular calcification. So it's no question that any patients, adult or pediatric patients, vascular calcification is part of the complexity of this disorder. And if you look about what happened with morbidity and mortality in these patients, cardiovascular disease continues to be the leading cause of death of these patients, and a good percentage of these patients still develop vascular calcification. Now, renal osteodystrophy is now defined as the alteration of bone morphology in patients with CKD. It is one measure of the skeletal component of the systemic disorders of CKD MBD that is quantifiable by histomorphometry of bone biopsy. So that's very important. That's only renal, when you look about the recent papers today, we talk about renal osteodystrophy only when we define what happened at the level of bone biopsy. But in addition to that, the classification of renal osteodystrophy now has to include three variables. Now, in the past, I showed you that turnover was the one that we used to classify the different type of renal osteodystrophy. But now, in the what we call the TMV classification, it should include, and you see now in papers over the last few years, in animals, in humans, where we include turnover, mineralization, and volume. So this is important because turnover reflects the rate of skeletal remodeling, which is normally the coupled process of bone resorption and bone formation. Mineralization, reflects how well bone collagen calcify during the formation phase of skeletal remodeling, and this is important. And then bone volume, which really, excuse me, which indicate the amount of bone per unit of volume, per unit volume of tissue. So these three criteria is what we use today when we classify the different subtypes of renal osteodystrophy. So when we look at biopsies in general over the last decade, basically it has been used as a research tool. And recently, this is one paper from adults in just a few years ago, when in a large cohort of almost 150 patients with different stages of CKD, this TMV classification has applied. And what you see here, the blue and light blue and dark blue reflect turnover, the green and light green reflect mineralizations, and the beige area is volume. So you can see at each stage of CKD, when you look at turnover, the light blue is low bone turnover. You can see that low bone turnover is a highly prevalent entity in adult patients with CKD, and the more advanced stages of CKD, the higher the prevalence of adynamic bone. Similarly, when you look about mineralization, it's basically normal in the vast majority of the patients in early and advanced stages of CKD. Bone volume, on the other hand, tend to be abnormal in a substantial proportion of patients in end-stage kidney disease. When we look at these classifications in children, this is a cohort of around 60-something children with CKD stages 2 to 4, you can see a kind of, most of the children have normal bone turnover at every stage of CKD. Very few of them have high bone turnover. So the development of secondary hyperpara high bone turnover is a late phenomenon. So, and in children, basically bone turnover is normal. On the other hand, when you look at mineralization by osteoid thickness or osteomaturation time, that markers of mineralization, what is very important that you can see that early in the process, there is abnormal mineralization. And the abnormal mineralization increase as your GFR diminish. And in patients on dialysis, I don't show it in this slide, the abnormal mineralization is a very important factor. Now, what is also, so that's important from the point of view of value of this TMV classification. Now, we use this TMV classification also to assess therapy. So this is a clinical trial that we did a few years ago in which dialysis patients were randomized to different types of vitamin D steroids. And all these patients, by criteria, they have secondary hyperparathyroidism in the baseline bone biopsies, as shown by the blue bar. And the yellow represent osteothickness, so the degree of mineralization defect that these patients have. And you can see at the end of the 8-month therapy, bone formation markedly improved in this dialysis patient, but the mineralization defect persists despite therapy with 125 and level of 25 hydroxy-D are within the normal range. So this is an issue that deserves further studies, and I don't have time to talk about it, but I will show you further information in the next slide. Another study, for example, this is studies in adults in which the effect of pamidronate was assessed in a cohort of patients post-renal transplantations, and you can see that after 6 months of therapy, a substantial proportion of patients develop a dynamic bone with this intervention. The bottom line is that these type of findings, you can only define them by histology. The biochemical parameters are poor predictors of this change, at least at the present time. Now, the other important thing that we need to keep in mind that over the last decade, there is a tremendous advancement of knowledge in the biology of the osteocyte. The osteocyte represent almost 85% of our bone cells. They come from the final stage from osteoblasts. And, over the years, we always thought that osteocytes were related to bone strength. However, Dr. Bonewall many years ago wrote a paper called, the title of the paper, which I really like, it was The Amazing Osteocyte. And I think it's very important because it's been described since then, is that these osteocytes have dendrites, that they communicate between each other, and there are capillaries. And also they express a number of proteins that play a key role in the metabolism of vitamin D, of phosphate metabolism, and like FEX, DMP1, sclerosis, FGF23. And when we, for example, this is one example that you can see the expression of, these are the osteocytes in histology, and we look at the expression of these proteins in bone in patients with CKD, and this is one example. For example, in CKD stage 2, this is the healthy control. You have very little expression of FGF23, and in CKD stage 2, you can see a significant amount of expression of FGF23. So these osteocytic proteins are upregulated very early in the course of the disease, and there I can show you many others like DMP1 and sclerostin, etc. But what is important is that this upregulation occurs while levels of calcium, vitamin D are within the normal range. And some of these patients, as Dr. Portale have shown a number of years ago, some of these patients are hypophosphatemic early in the course of the disease. So the link between the upregulation of this protein, the development of hypophosphatemia early in the course of the disease, and this mineralization defect that I mentioned before is something which is very important, I think, in the further understanding of the process in the context of children with chronic kidney disease. Now, more recently in adults, a similar study was done to look at the different osteocytic proteins at different stages of CKD, and you can see sclerostin is, even in CKD 2 and 3, upregulation of sclerostin, FGF23, PTH1R, etc. So similar upregulation that we have seen in children with CKD. Whether this upregulation of obviously of sclerostin play a role in the development of adynamic bone, obviously is an important thing to consider, because now, as you know, we have therapies anti-sclerostin, and then the question raised whether this type of therapy will be the way to go for some of these patients with adynamic bone and chronic kidney disease. So these are issues that obviously require a number of studies to take into to analyze the consequence of such therapy. We have also looked at what happened with these osteocytic proteins after therapy with 125. This was part of a study that we did a few years ago. So we have, these are the expression of the protein. This in this case was FGF23, DMP1, and sclerostin at baseline. And you can see after 8 months of therapy with 125, there is significant upregulation of each of them. So, and as I mentioned before, the mineralization defect in these patients persists. So the impact of these proteins on this process, we don't know exactly what is the mechanism, but it's, I personally think it's an important thing to think about it, and even whether therapy with 125 is the appropriate therapy in the context of CKD early in the course of the disease. So this is a separate issue that we can discuss about it. Now, the other thing that you can do with bone biopsy cord, you can take cells. So these are the bone biopsy cord. You can isolate it, osteoblast. You can let them grow in vitro, and you can study in vitro studies. So for example, this is work that's done by Dr. Pereira in our lab, in which she can look at the mineralization in patients with CKD, either with patients with low turnover or high turnover versus healthy control. This is the way that these cells mineralize on healthy control, and you can see the difference in patients treated with maintenance dialysis, regardless whether they have low turnover or high turnover. There is a mineralization defect. So why this occurs, we don't know, but this is really, these are cells from these patients, and you can see that the mineralization defect persists, and obviously it's an important thing because bone deformities persist in these children, and we don't know exactly what is the best approach to treatment. So another group that we were interested to study doing these in vitro studies was we've been doing studies in patients with ADPKD to characterize the lesion of bone in these patients. This is a study that we did with Dr. Chonchol in Colorado, in which bone biopsies of patients with ADPKD and almost really normal renal function, their GFR was around 90. And these patients, the vast majority of them have adynamic bone, higher level of FGF23. But when you look at the cells of these patients, and in vitro from those biopsies, you can see that the alkaline phosphatase activity is markedly diminished compared to healthy control, and they mineralize much rapidly than healthy control. And what do we know about these patients? In humans, it's been shown that these patients tend to have lower level of alkaline phosphatase. The fracture rate is markedly diminished compared to other type of causes of chronic kidney disease. So this is a specific entity that why the mutations on PKD1 plays in the biology of this process is not very well known, but clearly is consistent with the clinical data about the characteristics of these patients with ADPKD. Now, from a clinical practice perspective, is why you do a bone biopsy. Well, you would like to rule out some type of atypical or unexpected bone pathology, determine the bone turnover state, or to identify a mineralization defect. So this, I tell you a story of this patient. This is a home hemodialysis patient that came to me, referred by, this is an adult, it's been on home hemodialysis for more than 25 years. And this woman has, 12 months before, he has a femoral fracture. And then 8 months prior to the visit, he developed the left tibia fracture here. And then here, almost at the time that I saw her, she had this non-union fracture at the time of the visit. And the reason why she was sent to us was because they were ready to amputate the leg because of non-healing, all these fractures. And then when you look at this patient, she's been on home hemodialysis for many years. And one of the things that I noticed was the persistence of hypophosphatemia, which is a phenomenon very well described in patients on nocturnal hemodialysis, mainly by the Canadian group, that they develop hypophosphatemia, and many of those patients require phosphate supplementations in the dialysis to correct the hypophosphatemia. So I thought on this patient, well, maybe we should do a bone biopsy and see how her bone looks like. Well, we did a bone biopsy, and this, what you see here, this is osteoid. So you see this wide range here is osteoid, and this is the tetracycline labeling. So this patient has severe osteomalacia, really very, very severe. So we decided to treat this patient. We told them to add phosphate in the dialysis, as been done in Canada. This woman was wheelchair bound with significant amount of pain, as been described in many patients with osteomalacia. And within a period of 14 months, something like that, we repeat the bone biopsy. But before I mention that, I can tell you that within, I would say, 4, 5, 6 weeks, she called me one day and to tell me that her pain is markedly improving and she started to feel much better. And so within 4 or 5 months, her fractures start to improve, to heal, and she started walking, not using the walker anymore, and wheelchair, not wheelchair. We repeat the bone biopsy, and you can see here how the mineralization is markedly improved, and the tetracycline, she has already double label. So here is a nice case in which really the only way that you can make this diagnosis is by performing a bone biopsy. Now, if you move to what happened to patients with CKD, one of the main things that happen to adult patients with CKD are fractures. And fracture rate, despite every single treatment that we give to these patients, continue to be very high. And you can see here that this is a very nice slide in which you have patients with CKD from 3A to patients on hemodialysis compared to the general population shown by the black line. And you got any stage of CKD, the prevalence of fractures in this population is markedly increased. So fracture rate is a critical problem currently in dialysis and in transplant patients. And if you think about transplant in general, it happened with liver transplant, with heart transplant. This is a common problem that we see in that patient population where the strategy for therapy remains to be defined. Now, when you look about the strategies to assess bone fragility, well, we use clinical factors, age, history of fractures, steroid, diabetes, cardiovascular disease, CKD stage, biochemical markers, imaging markers, and then all of them really are poor predictor of the different subtypes of renal osteodystrophy. HRP-QCT, I know that UCSF is working on that, but it's a research tool, and maybe they have future, hopefully will, but at the present time, obviously it's not clinically used. So and we know also that in some CKD patients, low bone density by DEXA does not predict fractures like it happened in the general population. So if you want to know in that context, what does the patient have, the only way to know is by doing a bone biopsy. And I'll go back here to some KDIGO comments or recommendation, how it's been moving since 2015 to the present, starting in 2009, but I focus on the last few years. So in 2015, KDIGO said in patients with CKD 3 to 5D, it is reasonable to perform a biopsy in various settings, but not limited to unexplained fracture, persistence of bone pain, hypercalcemia, hypophosphatemia. And for this group is prior to therapy with bisphosphonates in patients with CKD MBD. Then in 2017, they came out with in patients with CKD 3 to 5D, it is reasonable to perform a biopsy if knowledge of the type of ROD will impact your decision treatment. So it's kind of more soft, everything. These are opinion-based, it's not graded. And then also they came out with some comments about, against CKD 3 to 5D, with biochemical abnormality of CKD, MBD, and low BMD of fragility fracture. We suggest that treatment choices take into account the magnitude and the reversibility of the biochemical abnormalities and the progression of CKD with consideration of a bone biopsy. And that they gave some rating. So basically, as you can see, in my opinion, these guidelines are very vague. And then what is more important is what we have different options to treat these patients. As you know, we can have PTH for osteoblastic activity. We have drugs that act on biphosphonate or denosumab on osteoclastic activity. So the only way that you can know which of them you will use at the present time, at least I feel, is by doing a bone biopsy. As you know, as I mentioned before, Wnt signaling is an important regulator of bone formation, increased osteoblastic activity and proliferation, increased bone formation, and sclerostin is an important inhibitor of the Wnt signal pathway. And so you can see that now that we have a drug to treat osteoporosis with an inhibitor of sclerostin, you can raise this question whether such drug should be used in patients with chronic kidney disease. This is an open question, but just to make the point that drugs are becoming available, but we don't know when to use it in this patient population. So in Europe, there is a European initiative of renal osteodystrophy between different countries in Europe, in which they came out with some papers from the working group saying it is time to halt the negative spiral on bone biopsy procedure. A biopsy often remains indispensable in the workup of low-impact fractures and in the setting of CKD. Low-impact fractures are common among CKD patients. Their prevention and treatment is challenging, at the same time frustrating because of the lack of evidence. And a more widespread implementation of bone biopsy as diagnostic procedure may widen the therapeutic horizon and may foster the development and validation of non-invasive alternatives. So in conclusion, it is time to rethink the use of bone biopsies to prevent, where they will be able to prevent fractures and bone deformities in adult and pediatric patients with CKD, and then to revitalize bone biopsies as a clinical useful tool in daily practice. The problem with this thing that most of the centers now do not do bone biopsies and they don't know how to do it. And there are very few centers around the country that probably 4, at the max 5 maybe, that they can do bone histomorphometry. So it's a tool that is kind of been abandoned in general in most of the training programs in nephrology around the country. So we think that what limits the innovation in renal osteodystrophy, and that is why there is no new things in renal osteodystrophy. And this because of multiple reasons. There is a few large-scale clinical trials, few treatment, small pool of investigators working on renal osteodystrophy, few targets for drug development. Is an invasive procedure, obviously. The lack of fully open access to a specific database on renal osteodystrophy. And so all these different factors really play an important, and there is a lack of modern and analytical methods and complex to obtain and analyze are required, a large scale. So these problems, I mentioned the issue of traditional bone histomorphometry, the variable that we use, and it's a good tool. But there are other tools that you can do with histology. You can look at nanoscale measurement of bone tissue quality that can give you some idea of mineralization and maturation that has never been utilized in renal osteodystrophy. The application of immunofluorescence to bone is providing a better understanding of bone signaling pathways that widespread dissemination of this data are not available, which limits really the drug development on ROD. These are data that is being done in our lab by Dr. Albrecht, in which this is a immunofluorescence for sclerostin, and these are the top are patients with low level of sclerostin, and you can see very little bone expression of sclerostin, and at the bottom, patients with higher circulating level of sclerostin, and you can see the number of osteocytes that they are positive for sclerostins are markedly increased. So it's no question that sclerostin play a key role in this pathogenesis of renal osteodystrophy, and obviously this type of tool help us to understand biology. And finally, there is a need to do single cell analysis in renal osteodystrophy that has never been done. It's been done only in animal studies, but in humans there is no data for the application of this methodology that really in the overall will allow us to understand pathways. And by understanding pathways, hopefully in the future, we will be able to understand new therapies. So for this reason, we developed something called the Renal Osteodystrophy Precision Medicine Project. This project was just funded a couple of weeks ago after 3 years. There's a combination of work between University of Kentucky, Columbia, Northwestern, and us, with the idea, what is this ROD Precision Medicine Project? It's a collaborative effort to address a main challenge in renal osteodystrophy research. We would like to create a large-scale, open and freely accessible resource to the research community to link clinical, histopomorphometric, and genomic data pertaining to renal osteodystrophy. So the aim of this project is first to establish the infrastructure, centralized, linking biochemical data, demographic data with bone tissue and transcriptomics on a weight-based platform. So we are going to do bone biopsies in a cohort of patients with chronic kidney disease and treated with dialysis. All these patients will have histology, immunofluorescence, all the different technology that I mentioned. And then we are going to do single cells on the same cohort of bone biopsies and to look at transcriptomic. And then this data will be web-based. So everybody will have access. And the main source, what NIH will ask us is how many investigators from around the country are using this tool. So this will be really, this will start hopefully in the next 10 months, 12 months, something like that. We just got the grant funded. And but the idea will be that access to put it in the public domain and for everybody interested in this type of studies to have access to this information. I personally think it's a very exciting period that will come up for the field that I think it will open and help us understand better the biology of this process. This is the group of my collaborators for this grant: Val David at Northwestern, Harma Luca at Kentucky, Tom Nicholas in Columbia. And these are my collaborators at UCLA and Colorado, MGH. I'm happy that Hank is here, and UCI. And I thank you very much, and I'd be happy to answer any question. Thank you.
Isidro, thank you so much. That was so interesting. I really appreciate it. I have a million questions that I can get started with, but I don't see any questions in the chat. But first, let me ask if anyone wants to jump in right now to start off.
Isidro, I'll jump in because that's what I do. I think this was a spectacular talk and a real tour de force, and I'm so glad you have that much needed grant to get more data, really, because you made a really strong case that we need data from real bones and real cells to understand what's going on. But having said that, there is the worry that you'll get a whole lot of data and then not know what to do to make the bones stronger. And so I think what you said at the end, to encourage investigators with therapeutic ideas to use your database as a beginning, but then with the various therapies, and you mentioned the anti-sclerostin, for example, it would be a wonderful kind of thing to try, but then to see in the context of all the different things you'll be measuring what's really happening. I think it's tremendously important. You showed us as a mineralization defect that we don't have a way of identifying, and that we've got this horrific fracture rate. So it certainly needs new work, and I think somehow or other using new therapeutics combined with all these things you'll be doing is going to be the way to come up with real advances in therapy.
Thank you, Hank. Yeah, I agree. I think it's time that we can open that and see how we can move forward the field, basically.
Dan, I see you have your hand raised.
What concerns me, excuse me, I have the flu here. What concerns me is that you're only doing, it sounds like you're only doing a couple of biopsies, and given the heterogeneity of renal osteodystrophy, I wonder if you're going to capture the breadth of the change, which laid out so very nicely in your introductory slides. And I'm also wondering if you are planning on doing some biopsies in normals, so that you get a sense of what genes, what pathways are altered, going from normal to your ROD patients.
Yeah, thank you, Dan. Yes, I agree. We are going to do biopsies in normal also. And that's very important. It's a critical issue. Most of those normal that people are doing biopsies are people maybe have some degree of osteoporosis, but the idea is really, this will be done only in adults. We are now in this first stage of the grant. We are going to do it only in adults. And so, yes, we are going to do biopsies in people with normal GFR. That's number one. The issue of heterogeneity, yeah, is very important. I don't know the answer about, we are aware about that. And I think this is the beginning. I'll be honest, this is something that we see how this data come up, see the kind of interest from the community, and then we will move from there. I think there will be hopefully a way that we will be able to identify new pathways that allow us to think about new therapies, basically. There's no question that we are not making advances in this field. It's flat, and that is an important issue.
I see a question in the chat, and then Dolores has a question as well. So do you know why children with CKD have growth defects?
I'm sorry, what the question was? Why?
Do you know why children with CKD have growth defects?
Oh, that's the $1 million question. I don't know. That is multifactorial. There are many factors involved. We've been dealing with, we are making progress. Children continue to grow better with therapy with growth hormone, better management of calcium and phosphorus and vitamin D, but still they are growth retarded. And it's difficult for them to have a normal growth rate. And so the fact could be nutritional factors. I'll be honest with you, there are many, many issues involved that we don't know exactly why. One, what is the impact of this mineralization defect, for example, in growth retardation? I don't know, but it's something that we see. So I don't have that. I don't have the answer for that. I wish I have it, but it's not there yet.
Dolores?
Sure. I was so intrigued, and I'm sure I need to do more reading about the sclerostin data that you showed, and from the bone biopsies. And I guess I would like to ask you, as a nephrologist, do you feel that this is correlating with changes in the vasculature, the MBD part of it, and vascular calcifications? And I guess maybe just tell us, as a nephrologist looking at bone biopsies a lot, what do you think that we can do with anti-sclerostin in this setting? Do you think that it will work in the bone and be dangerous to the vasculature in some way?
Yeah, you raise a very important. I just brought it up because as you know, it's an approved drug for people
Sure.
with osteoporosis,
Of course.
and so the issue in the context of, and as you know, there are cardiovascular problems also associated with this drug, and already the CKD patients are at higher risk of cardiovascular disease. So in this group of patients, I will be extremely cautious on what type of studies I will think about how to use it. The issue of vascular calcification to me is very important, and whether this enhances the calcifications, it may well, I don't know. I really don't know. What we know also, on the other hand, is sometimes patients with low bone turnover are those also who have more calcification. So because they tend to be more hypercalcemic,
Right.
so it's like a catch-22, and I don't know, where this type of intervention, whether it can have an effect or not. This is a very difficult and an important issue that we have to keep in mind when we decide to study this type of drug, but I don't have an answer. But it's no question that the expression of this upregulation of this protein is really occurred very early in the course of the disease. And my question is, where are the signal come from? Is the bone telling the kidney something, or is the kidney telling something to the bone? And this crosstalk is something that it will be very important that we understand better where does it happen, or what's the initial signal, where does it come from?
Will your database have information about anything beyond just events in the patient's life? I mean, will you have any, I don't know, echoes or anything where we would
Not
have...
in the initial step. Not
Okay.
in the initial step. I can tell you, this has been a struggle to get these things done, and so on, budget and this and that. So I think if we can get this initial step, and if I am convinced, if NIH see that the community, either for K award, R award, whatever, start utilizing this database, they would be extremely supportive. If you think about the kidney precision medicine, they are doing kidney biopsies. They are putting a lot of money in that project, and some things are coming up. Whether we can move in that direction, I don't know, but this which will happen. Yeah.
Great.
Isidro, speaking of the database, I was really excited to see that you have included in there FTIR and nanoindentation and those kinds of measures. And because earlier I was actually thinking that FTIR measures would be a really nice addition to that TMV evaluation. It would be like a fourth axis, or
yes.
So that's exciting. And then I immediately, as soon as I saw Columbia there, and I know that Tom Nicholas is a collaborator on that project, I was wondering if it's possible that HRP-QCT is going to be done on some of those participants, and whether that could eventually, through an ancillary funding mechanisms or something, become part of the resource.
It was in the initial phase of the grant. We put HRP-QCT, and then because of budget things, NIH decided they cut the budget. So he cannot do it. So I think this is something that it will be open up for ancillaries and figure out how we can do it. But initially it was in the plan, but they cut it. That's basically they cut it.
That makes sense. I see Dan has a hand up again.
Yeah, I'm wondering about FGF23. Are you planning to incorporate that into your studies? Excuse me. Did I come through? FGF23. I didn't see mention of that in terms of what you're going to be evaluating.
What are we going to evaluate?
FGF.
I understand. But you are asking me. Well, we know that
I'm wondering if you're going to look at that FGF23 relative to vascular calcification, whether that contributes to the osteomalacia as opposed to the high turnover bone. Just sort of wondering. You're doing biopsies, and I have not seen anybody who is looking at FGF23 on the bone at the level that you're doing to see if FGF23 correlates with any of the histomorphometric features of RID.
One of the interesting things about the FGF23 in adult and children higher level of FGF23 in advanced CKD dialysis patients correlate with better mineralization, which was unexpected.
Yeah.
And so that is kind of, when we saw it the first time, we were very surprised. I was expecting a different association. And then there is a group of adult bone biopsies in adults that found the same findings, higher levels with better mineralization. So, but why and what is the fact? These are associations, yes, what we have described. We would like to look more into these things. And as you know, FGF23, it may be the pathway of many factors, from mineral factor to non-mineral factor. But why those levels of FGF increase so early in the course of the disease? Yeah. Basically, is the first biochemical abnormality that you see in CKD. And so what is the signal that is upregulating the production of FGF23? All those things we don't know, basically. No, this is a very important area of work. We will look into these things and then trying to understand better the impact of FGF23, whether other therapies, and also I personally think it's beyond bone, because it's also another factor which is important in the context of FGF23 is non-mineral factor like iron deficiency. Iron deficiency is the most common, it's very common on CKD, and it starts early in the course of the disease. Iron deficiency stimulates FGF23. So there you can see a kind of an interesting interaction between mineral and non-mineral factors stimulating the production of FGF23, and both factors occur very early in the course of the disease. On top of that, you have inflammation. So there are many, many factors involved, but evidently this, what is a primary factor FGF23 or FGF23 is the consequence of, a final pathway of different signals. I don't know, but yeah, these are issues that we will be looking very carefully.
And another question that came to mind while you were talking about the basics of bone biopsies and the histomorphometry that you do, I'm wondering if you have ever considered a 3D histomorphometry technique, and whether you can imagine that would give you any additional information. And I'll tell you.
I'm sorry, I didn't hear. What did you say? If I consider
a 3-dimensional histomorphometry.
Oh, 3-dimensional.
Yeah.
Yes, that would be. Yeah, it would be great. We've been talking about it. It's not an easy thing to establish, but we've been trying to figure out how we can implement 3-dimensional. Yes, absolutely. Yeah.
Well, maybe we'll talk about that a little bit. I'll send you some info, because it's been a pet project of mine for a long time, like since my PhD days. And Chris Hernandez actually then took it on and developed it a little bit more at Case. And so there's a sort of a skeleton of the idea, but it's so hard to implement.
Many years ago, we started playing with it. We look at the bone biopsy core and micro CT just to see, the associations and see what happened. Yeah, there were some interesting associations, but it's a very tedious technique. And and then the person who was doing that work left, and so we drop it. That's
yeah. Any more questions from? It looks like Zara has a question. Zara, do you want to unmute and ask your question?
Yeah, thank you. That was a great talk. Thank you, Dr. Salusky. I have 2 questions actually. They're very little clinical. I was wondering about the anterior superior iliac crest region you mentioned. So do you run into the problem of any nerve injury, any complications when you perform it anteriorly? And why not use the posterior iliac crest, which is more performed with other kinds of hematological biopsies?
Yeah. No, I do not have any problem with injury. I'll be honest, I've been done a lot. And it's the same thing for other groups who've been doing this type of procedure for many years. None of them have reported this type of, can have a little hematoma. People can talk about fractures, but the morbidity is minimal. And the reason why, I'll be honest, we didn't use the back is because basically the control that we have are also from the anterior iliac crest. And traditionally was people start doing this, and it's been continued like that for decades, basically. And so just to change the site, and it will entail a number of new controls. So that's the way I learned how to do it. I'll be honest with you. And this is, we established the controls. So that's the way that was initiated this process maybe 50 years ago, 45 years ago. And we continue now. Whether it may be you can get similar things on the back, but I don't have any experience. I know now we are doing a study with Joe X from San Diego, in which we are looking at bone of patients on kidney disease that have fractures. So the patient had a fracture of the femur, etc., and then a piece of bone come to our lab, and we are trying to look about what type of histology this bone have, or whether they have secondary hyperpara, type of, how this, we can think about how this cannot be associated with what we see at the level of the iliac crest. But that is access, basically was the access, the way that I learned about it.
And secondly, what do you think about repeat biopsy of these patients for treatment response? I mean, how many times can we biopsy these patients?
Well,
will be.
Yeah.
Yeah.
I have done a number of clinical trials with repeat bone biopsies. And so you can see changes in bone biopsies after, I will say, easy 8 months of intervention. In the patients that I've done, almost 80–90% of the patients, and these are kids, came back for repeat bone biopsies. I didn't, because it really is safe, they feel comfortable, they don't have pain, and they come. So I've done a number of those trials. So whether you can do it 2 or 3 times, that is a separate story. But at least I would repeat, if you do an intervention within 6 months to 12 months, it will be a nice time to see the effect of your intervention. There are some people who have done 2 or 3 bone biopsies, subsequently. There is a study in Europe a number of years ago where they did 3 or 4, I don't remember exactly the number, in the same group of patients. So but in general, people have done 2. Whether you want to do more, I think it is an issue more related with the type of therapy that you would like to assess and what you would like to take more out of this intervention. But at least 2 is not a problem.
Thanks.
Isidro, thank you so much. I think our time has come to an end here, and I know you have a full afternoon of meetings, and thank you so much for taking all that time to meet with us, including, I think, a junior investigator committee time slot. So if anyone here is interested in joining that, let me know and I can connect you to that. And
those of you who want to learn how to do a bone biopsy, I'd be happy to teach you. So you can come here. I'd be happy to go up there. Any way you want, we will be happy to do that. I've done it with other groups, and it works. I tell you, it works. Or you can come down here and you see how I do it, and I will be happy to follow through. Okay, so feel free to contact me.
Fantastic. Thank you. Maybe we set up a CCMBM workshop for bone biopsy.
Yeah, that would be good. Yeah, that would be a good idea. Yeah, you can ask also Joe X from San Diego, and then that would be great. Yeah. All right.
Thank you so much.
Everybody. Take care. So I need to change I need to go to another, I need to change the.
I think so.
Yeah. Okay. Thank you, everybody. Bye. Take care.
Take care. Bye.